Physiology SAQ 6. A. Briefly describe the fetal circulation, 5 marks. In the fetus, there are two separate vascular circuits in parallel, not in series like in the adult circulation. Non-functioning gas exchange in the lungs, high blood flow in the placenta. Placenta allows exchange of gases, nutrients, and waste products. Circulatory adaptations to minimize blood flow to the liver and lungs. There is massive right to left shunt. Gas exchange occurs at the placenta, and the oxygenated blood from the placenta returns to the fetus via the single umbilical vein, the ductus venosus, and the inferior vena cava to flow into the right atrium. Here, this oxygenated blood is redirected via the foramen ovale towards the left atrium and is pumped by the left ventricle, mainly to the head and the forelimbs. Blood from SVC and IVC drain into the right ventricle, which is pumped by the right ventricle into the pulmonary artery, where the ductus arteriosus makes a connection to the descending aorta. Because of high pulmonary vascular resistance of the fetal lung and low resistance of the systemic circulation through the placenta, flow through the ductus arteriosus is preferential. Fetal circulation adaptations. Two umbilical arteries from the internal iliac arteries to the placenta and one umbilical vein from the placenta to the IVC and liver allows exchange of gases, nutrients, and waste products with the placenta. The ductus venosus from the umbilical vein to the IVC near the confluence of the umbilical vein and left portal vein allows 50% of ductus venosus blood to bypass the liver. The foramen ovale is a hole between the left atrium and right atrium, allows 60% of IVC blood guided by the crista terminalis to flow across the foramen ovale to reach the left atrium. This causes the brain to receive most oxygenated blood. The ductus arteriosus lies between the main pulmonary artery and aortic arch, allows 90% of right ventricular output to bypass the lungs. B. Describe the changes which occur in the fetal cardiorespiratory system for adaptations to extra-uterine life, 5 marks. Fetal adaptations need to be reversed for extra-uterine life. Physical changes at birth includes breathing and cord clamping. Breathing results in aeration of alveoli, increased PaO2, reduced HPV and reduced PVR. Cord clamping is due to physical clamp and hypothermia-induced contraction of Wharton's jelly, increases SVR, and causes loss of maternal prostaglandins. Respiratory changes includes loss of placental gas exchange, reduced lung fluids, initiation of ventilation of the newborn's lungs, increased surfactant production, expiratory breaking, establishment of FRC, and commencement of pulmonary gas exchange. Circulatory changes includes reduced PVR and increased pulmonary blood flow, umbilical artery and umbilical vein closure, ductus venosus closure, foramen ovale closure, increased hepatic portal blood flow, increased SVR, ductus arteriosus closure, increased renal blood flow, and changes in skin blood flow. Respiratory changes. Loss of placental gas exchange is due to umbilical artery and umbilical vein closure. Reduction in lung fluids. Before delivery, the fetal lung at term contains about 20 ml per kg of fluid. Some of this is expelled during thoracic compression during vaginal delivery. With the first few breaths, there is cessation of the production of fluid in the lungs, and there is increased absorption. Initiation of ventilation of the newborn's lungs. The first few breaths is stimulated at birth by exposure to the environment of the outside world. Hypoxia, hypercarbia, and the stimulus of cold receptors stimulate the breathing centers. The first breath requires a very large negative intrathoracic pressure, but subsequent breaths become progressively easier due to the establishment of an air-liquid interface and the action of surfactant. There is a production of large amount of surfactant stimulated by the air-fluid interface created by these breaths. Surfactant reduces surface tension of the air-liquid interface in the alveoli, increasing lung compliance and reducing work of breathing. Expiratory breaking occurs where after inspiration the glottis closes and expiration does not follow inspiration immediately. This creates positive pressure in the lungs and helps recruit and expand alveoli. Crying and grunting also helps this process, which creates positive expiratory pressures. Establishment of FRC. By 10 minutes, FRC is 17 mL per kg, and by 30 to 60 minutes after birth, FRC is 30 mL per kg normally, which is almost the same as an adult. Commencement of pulmonary gas exchange occurs to deliver oxygen to tissues. Oxygen consumption of the neonate is 7 mL per kg per minute, twice that of an adult. Circulatory changes. Reduced pulmonary vascular resistance and increased pulmonary blood flow. With the expansion of the lungs, there is a development of low resistance in the pulmonary circulation. Better oxygenation of blood reverses hypoxic pulmonary vasoconstriction due to the hypoxia of intrauterine life, further reducing pulmonary vascular resistance. Umbilical artery and umbilical vein closure. This occurs from physical cord clamping, hypothermia-induced contraction of Wharton's jelly, and umbilical blood vessels constrict in response to stretching. UA and UV closure results in increased SVR, loss of umbilical circulation to the placenta, loss of maternal prostaglandins, reduced right atrial pressure due to reduced venous return. Ductus venosus closure. Loss of placental blood flow stops most blood flow through the ductus venosus, and this closes off. Over the succeeding days, the DV closes off. This results in increased SVR and reduced right atrial pressure due to reduced venous return. Foramen ovale closure. Functional closure occurs due to reduced RAP and increased LAP. There is a fall in right atrial pressure and right ventricular pressures, and there is an increased pulmonary blood flow leading to increased blood returning to the left atrium, and this increases left atrial pressure. As a result, there is a functional closure of the foramen ovale, which occurs within the first few breaths. Increased hepatic portal blood flow. Closure of the ductus venosus raises the portal venous pressure, which encourages portal blood to pass through the liver. Increased SVR occurs due to cord clamping and DV closure. Ductus arteriosus closure. There is reversal of flow through the ductus arteriosus and constriction of the ductus arteriosus due to increased oxygenation of the blood by the lungs and loss of circulating prostaglandin PGE2, a potent vasodilator produced by the placenta, with a functional closure developing within 96 hours and anatomical closure within 2 to 3 weeks due to intimal fibrosis. There is increased renal blood flow due to reduced renal vascular resistance. Changes in skin blood flow depends on environmental temperature and thermoregulation. As a summary, functional closure of the umbilical artery occurs within minutes, permanent closure occurs within days due to fibrosis, functional closure of the umbilical vein occurs within hours, permanent closure occurs within 3 to 10 days due to fibrosis, functional closure of the ductus venosus occurs within hours due to stasis, and permanent closure occurs within 3 to 10 days due to fibrosis, forming the ligamentum venosus. Functional closure of the foramen ovale occurs within minutes. Permanent closure occurs within 4 to 6 weeks. Functional closure of the ductus arteriosus occurs within 12 to 24 hours, and permanent closure occurs within 2 to 3 weeks. Normal parameters for neonatal circulation: heart rate 120 to 160 beats per minute, compared with 60 to 90 beats per minute in the adult. Stroke volume is fixed. Cardiac output is 280 mL per kg per minute, compared to 70 mL per kg per minute in the adult. Systolic blood pressure is 70 to 90 mmHg, compared to 120 mmHg in the adult. Physiological shunt is 20% in the neonate, compared to 7% in the adult. Reversion to fetal circulation may occur if there is reduced PaO2. This results in reopening of the ductus arteriosus. Reduced PaO2, increased PaCO2, acidosis and hypothermia can increase PVR, which increases RAP, and this leads to reopening of the foramen ovale. For transition to extra-uterine life, the two parallel circulations are converted to two vascular circuits in series with high pulmonary blood flow and cessation of placental blood flow.